All right, you're good to go.
Okay, guys, good afternoon. So I'm gonna actually take over this talk and just try to make it as brief as we can. Uh, Nick was supposed to talk about what kind of devices we have and the indication for these devices, and I think we went through that before, but I think we can just talk about the indications again and devices because it's really a very relevant topic to cardiology and electrophysiology. So, as you may know, we have different kinds of devices. We have pacemakers, and they run as single chamber pacemaker, dual chamber pacemakers, and biv pacemakers. And we have the ICDs defibrillators, and we have the ICD BiVs defibrillators. The ICDs can be dual chamber, single chamber, and the BiVs, you have LV lead, RV lead, and RA lead. And sometimes if your patient has atrial persistent or permanent atrial fibrillation, no need for atrial lead, only you do LV and RV lead. And then also you have the loop recorders for heart monitors. Battery right now actually lasts between 3 to 5 years, depends uh, on what kind of device you have. Nick from St. Jude, from Abbott, but we have Abbott, we have Medtronic, we have Bytronic, and we have Boston Scientific. These are the four companies that we use. The most common one is Medtronic, about 60% of the market, and then you have Boston Scientific is about 20%. Then you have St. Jude's about 15%. Then Bytronic is about 5% of the market. So if you're in doubt, most of the time, 50, 60% of the time is going to be Medtronic. All these devices have remote monitoring capacity. Some of these remote monitoring devices, you have to plug it in the wall. Some of them actually, it's an app uploaded to your iPhone. But if you're a nursing home resident, most of the time you're going to have it as a device plugged in, and probably a lot of times you're going to see some of these patients without remote monitoring capacity because of the movements, and a lot of these devices get lost and so forth. The remote monitoring, it will communicate with the device almost on nightly basis between 2 to 4 a.m. So it's crucial for you to have the remote monitoring device at night where patient sleeps, not in the bedroom. Obviously, if they are at the nursing home facilities, they only have one room and should be there where they sleep about, less than 10 feet from the head of the bed. That where the device is going to be able to communicate with the pacemaker itself, or the loop recorder, or the ICD, and so forth. Now, indication about devices, pacemakers indications, any kind of sinus node dysfunction that is associated with symptoms. Now, not any bradycardia can buy you a device. So you have to have a correlation with symptoms. In other words, if you have sinus pause, sinus node dysfunction, you have to have a temporal association between the sinus pause and feeling dizzy or syncope. Um, Most of the time, sinus pause at night is not going to really buy you a pacemaker, no matter how long it is. So the Heart Rhythm Society is very critical about this. You doesn't want you to treat pauses at night with pacemaker. They want you to treat pauses associated with symptoms for pacemakers. Pauses at night most of the time are associated with sleep apnea or some just high vagal tone, but the temporal association is critical. If you have chronotropic incompetence, your heart rate doesn't go up enough with exercise. That is another indication for pacemaker. That's called sinus node dysfunction. The way we evaluate that, we put patients on treadmill and we'll see if they can achieve 70% or more of maximum predicted for age, which is 220 minus heart rate. If they're not able to achieve above 70%, then pacemaker is indicated in that case. And these pacemakers, most of the time, they have rate response. So when you do any activity, device will sense it. It's accelerometers, and uh, these accelerometers actually is going to give you increased heart rate based on algorithm. And actually, you can adjust it based on your for your patients. If you have athletic patient versus patient who's elderly, and the rate response is going to prevent fatigue related to bradycardia. So that's another indication for pacemakers. These indications are under sinus node dysfunction, and atrial lead is a must in these cases. Um, AV nodal block, not any AV nodal block. The indications are for second degree Mobitz type 2 AV block. There's association with complete heart block and association with asystole, so pacemaker is needed. You should have RV lead, so you should be dual chamber most of the time. And then if you have complete heart block, then pacemaker is needed. Now, how about you have Mobitz type 1 AV block? Is if Mobitz type 1 AV block is not associated with symptoms, there's no indication for pacemaker. However, there's another indication if you have somebody with trifascicular block, first degree AV block, right bundle branch block, and left anterior fascicular block, or first degree AV block and left bundle branch block, which is the anterior fascicle, posterior fascicle, called trifascicular block. In the setting of syncope, pacemaker is needed. So trifascicular block in the setting of syncope is pacemaker is needed, not any first degree AV block, not any Mobitz type 1 AV block, but anything Mobitz type 2 AV block and above, you really need to have a pacemaker. So you should be really mindful about it. So Mobitz type 2 AV block and complete heart block, you don't have to have symptoms. So there's indication for pacemaker because of the fact there is association with asystole in these patients, about 4 or 5% per year. So you have to be careful about that. There are another indication for pacemakers, such as neurocardiogenic syncope. It's really very soft indication. If you do tilt table test and patient has the pause 15, 20 seconds associated with syncope, pacemaker may be indicated. It's not really absolute indication because it's just in clinical trials did not really improve outcome very much. So, soft indication. And if you have carotid sinus hypersensitivity, a failed medical management, and somebody who's elderly, whenever they move their head or shave, whatever, they get syncope because of pauses, then pacemaker is needed. Now, as far as single chamber device or leadless pacemakers, they are indicated for certain indications. If you don't really need much atrial pacing, if you really don't need a lot of RV pacing, for instance, in the setting of sinus pauses, you may have sinus pause every once in a while, a couple days a week or something like that for a few seconds. Leadless pacemaker or single chamber pacemaker is okay, but beyond that, you have to be really having device with dual chamber device that's going to give you synchrony. Now, if you don't have access because of subclavian issues, because of compromised access in relation to the hemodialysis catheters and so forth, high risk of infection, leadless pacemaker is indicated. But if you're going to have leadless pacemaker, the ability to sense the atrium is minimized, even though the new Medtronic one, it can actually, based on the sounds coming from closure of the tricuspid valve, they can assess the P wave, and based on that algorithm, they can actually sense a little bit of the atrium, but it's based on my experience, it's just very weak. So be careful about choosing a single chamber device because you're gonna lose atrial synchrony unless you have patient with permanent atrial fibrillation that you really don't care about the atrial activity. Do you have any questions about pacemakers and stuff like that?
I have the questions.
Yeah, sure.
Hey, I have a patient in nursing home. She's at 90. She went to the hospital, complete heart block, and the family refused pacemaker. Is there any risk for her being like a 90 years old? She doesn't really have much other issues, health issues. What do you think?
How about dementia?
Mm, no.
Yeah, I mean, I would not do that. I would actually indicate, I would do pacemaker for her because complete heart block for somebody who's 90 years old is going to make the rest of her life miserable.
Right.
Even though you're not going to improve survival much, but having heart rate of 30s, 40s all the time is going to make her miserable. And pacemaker takes about 20 minutes to be done. Complication
Okay.
rate is very small, so I would not really suggest that. But if she's severely debilitated, if she's bedbound with multiple back ulcers from decubitus ulcers and demented, in that case, I would really think about it. Would you want to prolong survival of somebody like that? But if she's able to communicate and she's able to take care of herself to a certain degree and
Hmm.
have some kind of functional capacity, I think not doing the pacemaker in the setting of complete heart block is a mistake.
Okay. I'll talk to the family again and her.
Yeah, yeah, yeah. Pacemakers really much nowadays take about 20, 30 minutes, complication rate less than 1%, and makes you live in dignity because soon enough, with the decreased perfusion to her brain, she's going to have actually mental issues and she's going to go downhill fast, very fast.
Okay. All right. Thank you.
Hey, I got a question.
Yeah, go ahead, Tara.
Post pacemaker insertion patient in a nursing home facility, what's some just common or really pertinent red flags versus common normal variations or expectations you want us to be alerted to?
Sure. If the incision is red, inflamed, with discharge, discomfort, pain, swelling beyond what we expect with a little bit of hematoma related to device insertion itself, we have to worry about that. And then if patient is having syncope, if patient is having severe chest pains, indicating perforation from the lower chest all the way to the diaphragm. So stuff like that, I would worry about. Decreased blood pressure, like hypotension, that may indicate late perforation with pericardial effusion. Stuff like that, we have to worry about it. Now, if you're going to interrogate the device, you're going to see decreased sensing. So if you're sensing R wave of 5, 6, 7, or whatever, and you're sensing R wave below 1, that's another indication of perforation. If your impedance was 600 and all of a sudden your impedance is 1800, the higher the impedance, the higher likelihood of perforation you're going to have. Um, and the lack of sensing or pacing in the device, and like if the device is over sensing, so it's going to underpace because of over sensing. So you're going to have pauses, you're going to pass out. And if the device is actually under sensing, in that case over pacing, you're going to look at the EKG or the heart monitor and you're going to see paced complexes in the setting of existing QRS without having certain distances between the complexes and the QRS, native QRS. In that case, the device fails to sense and it's overpacing, and that's another indication of lead dislodgement. So the indications nowadays for devices to have interrogation within the first 1 month after implantation. So just keep that in your mind. If you have patient with a recent device implantation, try to get that device checked within 1 month. The standards of care.
Perfect. Thank you.
Thank you.
I
Any
have a
other questions?
question. This is
Yeah.
Jennifer. So,
Hey.
just being new to this area and of a specialty, I know that it would be like extremely helpful. And I don't know if you guys already have composed like a little cheat sheet for what the interrogation reports that you do on like all of our patients. There's a lot of information and I'm trying to learn it all, but red flags that really need to, be brought to attention. Jamie's been great emailing stuff like that, but there's a lot of acronyms and impedance and I'm still learning. So do you have anything like that
I
would be
think
maybe
I think
help?
I think I can work with one of these device reps about something like that. If your sensing falls, if your impedance goes up, if stuff like that. Actually, that's very reasonable. Yeah, we can work on
Doc, I
something like
think
that.
Natalie I think Natalie has worked on something like that. Let me,
We do, yeah. So
Let-
we have
oh,
we have a cheat
there we go.
sheet, and I'll share it with you, Jennifer, and can post it to the group me too.
Yeah, and maybe if Doc can just kind of, review over that too, and anything that he may see that needs to be added that we need to pay attention to, like in the clinical setting, be helpful.
Yeah, that's really reasonable. Yeah, I agree. I think even for the cardiologist, it's just some of these terminologies are a little bit, difficult to track and understand. I agree with that. Any other question? All right. So ICD indications. EF 30% or less is the clear indication for primary prevention for ICDs. For secondary prevention, anybody with sudden heart arrest or sustained ventricular tachycardia, ICD indication is there. And if somebody with unexplained syncope in the setting of structural heart disease, EP study is reasonable, and the EP study, if the EP study indicates VT or VF, then ICD would be indication. So keep in your mind that EF less than 35% is the key, or if you have history of sudden heart arrest or VT, VF, then ICD is indicated. The BIV ICD indications, if you have QRS duration more than 150 milliseconds, and in the setting of ejection fraction less than 35%. So you have to have right bundle, left bundle. We prefer left bundle branch block. And you have class 2 to 4 heart failure, ambulatory class 4 heart failure, somebody who's moving around even though they are on, let's say, milrinone, but they are moving. And if you have ejection fraction less than 35%, wide QRS, that indicates desynchrony. So desynchrony, or septum, left side septum or lateral of the left ventricle. So if you insert 2 wires to both sides on the septal side and on the lateral wall of the left ventricle, by accessing the coronary sinus, you can send electricity at the same time, and that will create synchrony. Success rate is about, the response rate is about 70% in these patients, and that's indicated before doing mitral valve clip or doing any of these interventions. So you put your patient on guideline-directed medical therapy, ASR, sacubitril, valsartan, Entresto, MRA, aldactone, eplerenone, put them on SGL2 inhibitors, put them on beta blockers, and 3 months later, EF continues to be down below 35%. In that case, BIV-ICD is indicated. And that's going to actually improve survival. And a lot of patients, EF may improve, especially in patients with non-ischemic cardiomyopathy and left bundle branch block. Do you have any questions about ICDs and BIV's indication? Now, BIV pacemaker, if you expect that your patient is going to need more than 40% RV pacing, and if their ejection fraction between 35 to 50%, BIV pacemaker is indicated. Do you guys have questions about that?
No.
I have a question, and I'm not really sure. Like when you do the interrogations, and if you see that adjustments need to be made, does that have to be done by like the outside cardiology local here? I don't know if that's done from a computer, or do they have to follow up with like their primary that inserted it to make any adjustments to the devices?
No, actually, if you're a provider and you have somebody who like Jamie can do the adjustments, if there's provider attending, it doesn't really need to be done by electrophysiologist or cardiologist or primary care physician.
Okay.
But or they have to have the device rep has to have an order by provider to adjust. So the device rep can adjust on his or her own, or you can tell Jamie, for instance, I want these adjustments. And if she suggested to you that, hey, I want this, I think these adjustments are reasonable, you can give the order and do the adjustments. Adjustment doesn't need to be really in a place where you have a cardiologist.
Okay, I wasn't sure how that worked. I haven't encountered that, but I do have someone that went to outside cardiology I picked up, and they had to do that. So I just was wondering. Thank you.
Yeah. Sure. Any other questions? Shay, do you want to ask something you were trying to ask? Okay.
Who, me? No.
Shay.
Oh.
Okay, so we talk about IVICD indications. Nick was supposed to talk about modes. You guys probably familiar of the three letters, four letters. The first letter where the device paces, second letter where the device sense, and the third letter where the device what kind of response to sensing, and the fourth letter is for rate response. So if we say DDD, R, meaning that they have dual chamber device, it will pace in both atrium and ventricle. It will sense in both atrium and ventricle, and the response of sensing is going to be either inhibit or pace based on what kind of response or what kind of sensing you're going to have in the atrium and the ventricle. So that's DDDR, or rate response. If I say VVI, okay, VVIR, the first V, you're going to have pacing in the ventricle. The second V, you're going to have sensing in the ventricle. The third I, which is the third letter, which is I, you're going to inhibit only. So the device will pace all the time unless there's activity in the ventricle, because you're not going to have atrial lead to track. So you're not going to sense and pace, you're going to just inhibit. So device will inhibit based on the right ventricular activities, and that's what we call VVI inhibit or rate response. So that's single chamber device. How about DDDI? You're going to pace in both, you're going to sense in both, but you're going to only inhibit. And these devices, if you think that you have some atrial craziness that you really don't want to track, then the device will not track them. It will only inhibit in case of the device feels something going on in the RV or RA. How about VDI? PACE, which is a single chamber device, which is the device that Medtronic, leadless, that it can sense the ventricular closure of the tricuspid valve. That's called VDI. Is going to pace in the ventricle, is going to sense in both, and it's going to inhibit only if it senses activity in the ventricle. So that's called VDI. So that are the terminology we use. There's another terminologies like DOO and stuff like that, which is going to be, we do interrogations like that during magnetic response and during MRI and stuff like that. But I don't think you need to worry about that. Do you have questions about these pacing modes?
Actually, Doc, can you go into the modes that you would tell it to be for an MRI? Because I have had that come up, people wanting clearances for
Yeah,
MRI. So
so-
you put it in DOO and you do a heart
Yes,
rate.
I do dual chamber device. I'll do DOO 80. Single chamber device, I'll do VOO 80. And this how the way I do it nowadays for MRI mode.
Do you have
So the
like a
device-
recommended resource that we can like refer to for this? Because I really want to understand it, but I might have to like read
our
it.
tip
Read it.
in that document that Natalie built.
I think it's in, yeah, I think, well, let's
Okay.
work on that.
Thank you.
I think I used to have books about pacemakers and stuff like that, which is actually, they are neat. I haven't looked at any of them lately, but there's something we're probably going to figure out something. I'll talk to the device reps and see if we can get some of these small books. Yeah. When you review a report, you're gonna take a look at a few things. Number one, the integrity of the leads, threshold, sensing, and impedance. Threshold, sensing, impedance. The device most of the time actually is going to give you alert if the impedance is out of range, and your sensing in the RV should be between 2 and above. Sensing in the RA should be between 0.5 and above. Threshold, it depends. LV threshold sometimes is high. because you're really pacing on the epicardial part of the left ventricle. But in general, threshold in the RA and RV should be less than 3, and threshold in the LV should be less than 5. Impedance range between 200 to 1800, but what it's really important, if you have impedances going 400, 500, 600, 400, 500, 600, all of a sudden they are 1600, even though they are within range, but the acute change may make you think about it. So what you have to do, you look at the sensing and you look at the threshold. If the sensing went down from 8 to 2 and the threshold went up from 1 to 3, your lead is failing. So you have to be alerted about that. You always need to look at the battery longevity for your devices. That's really very important. And it will give you battery longevity. It should be more than 3 months. Anything below 3 months, you have to replace it. Again, testing, when you test the leads, you have to test sensing, impedance, and thresholds. You have to take a look at the atrial fibrillation burden. Any AFib burden more than 1%, I would suggest anticoagulation. Any AFib lasting more than 24 hours, I would suggest anticoagulation. Any patient with atrial fibrillation, history of ischemic stroke, I would suggest anticoagulation. Obviously, if the AFib above 30 minutes or so. And in my clinic, I used 3 hours. If you have 3 hours of AFib burden, I would use anticoagulation. It's very controversial. The data we have, anything above 24 hours, you will benefit from anticoagulation. Anything between 6 minutes and 24 hours, it's questionable. You may benefit, but it was really questionable in the clinical trial, and the bleeding risk was really high in this patient population compared to the benefit. So it's shared decision with your patient. And the higher the burden of atrial fibrillation, the higher the likelihood that your stroke risk is going to be increased. Okay. Any question about all of that? Okay. All right. So I know a lot of information actually over really short period of time. I don't think it's a bad idea to have Nick again come back and just reiterate what we talked about. He's probably going to talk about his devices, which are Abbott, but they're going to be the same concepts with Medtronic, Boston Scientific, and Bytronic as well. And I really would like to have some presentation of certain device interrogations. I'm going to ask him if he can show us like at least 10 interrogations, go over them. So I've done it actually probably twice before when the group was small. We recorded the data, and some of them actually we have to take it down because actually there are some protected health information on these pacemaker interrogations that we just overlooked. So anyway, I don't think it's a bad idea for us to go over those again. It's a complicated topic, but I think we can make it easier by just keep talking about it.
I agree. Could you tell, like, what would be indicated for a loop recorder for like 3 or 5 years?
Palpitations that you could not capture on regular monitors. Let's say I get severe palpitations 2 or 3 times a year. That's indication. If you have syncope and collapse, that you really don't know the indication. If you have cryptogenic stroke is another indication to rule out atrial fibrillation. And in some cases where you have to manage atrial fibrillation, like you did an AFib ablation on these patients, their CHA2DS2-VASc score is 1.5, 2, and your patient is asking you to stop anticoagulation. It's not unreasonable for you to do loop recorder implant. If your CHA2DS2-VASc score 3 or more, then anticoagulation regardless is indicated. But in certain indications for AFib management also, let's say you have somebody with AFib, you did the AFib ablations, continue to have palpitations, you don't know if they have flutter versus fib, loop recorder will help you in AFib management. So AFib management, cryptogenic stroke, syncope and collapse palpitations.
Thank
Dr.
you.
Dr. Abraham, can you tell us a little bit about the procedure itself? Often when I talk to patients about a pacemaker exchange and the families will ask what is involved, I always defer and say, that doctor will go over the procedure. But can you tell us about loop recorder? Is that done in the clinic under local, about pacemaker, general anesthesia, and insertions, just so we can give them a better overview?
Right. Number one, I will stop anticoagulation 2 days in advance. I would not worry about antiplatelet agents. You have to be NPO. Loop recorder, you don't have to be NPO for loop recorder. It's local anesthesia. You can drive yourself and you can drive back. Loop recorder, if you don't want to stop anticoagulation, it's okay not to stop anticoagulation. The incision is very small. And it will be done under local anesthesia, and the incision that we do will suture it with 1 stitch, absorbable most of the time. The pacemaker itself, let's say dual chamber pacemaker procedure takes about half an hour. You have to stop anticoagulation. You have to be NPO. We'll do it under moderate sedation most of the time, sometimes under general anesthesia. We'll make a small incision, go from there with micropuncture technique to the left subclavian vein, insert 2 wires. You have to, after procedure is done, no shower for 3 days, no driving for 7 days, no anticoagulation for 3 days. And then, unless you have another indication for anticoagulation, mechanical mitral valve, you have to resume it as soon as possible. And you cannot move your arm above your head behind your back for 2 weeks. I used to do 1 month, but it's really too much. But 2 weeks is reasonable. I would not carry anything above 10 pounds in my left arm for 2 weeks as well. The reason is you don't want to move your arm above your head behind your back because you stretch this muscle. Usually it takes about 1 to 2 weeks for the leads to get attached to the heart. And in that case, you're not worried about movement that's going to dislodge your lead. Also, always remember that your patient should not really have the sling more than 24 hours. If they want to have it at nighttime, it's okay, but beyond that, no, because they will have frozen elbow, frozen shoulder. So you don't just be careful. Don't just leave it, because hospital will send them with it and they will have it for 2 months sometimes, which is really a mistake. ICD, the same as pacemaker, exactly the same. By V's takes about 40-50 minutes, sometimes 1 hour, depends on the anatomy and the LV lead. The same under sometimes general anesthesia, sometimes under actually moderate sedation, and the same precautions. Any other questions?
Does our company, are we able to interrogate or get the information from the loop recorders?
Yes, website. So if your patient is on your website, you should be able to actually get information, especially by Tronic. Yes.
I have a question also. Is there is it 7 days or 14 days when you're putting the heart monitors on patients when you're evaluating for a syncope or AFib? Is there a number of days that you recommend?
7 days.
7 days? Okay.
Yeah, I did it actually. I did the study internally myself, and I did not really find difference between 7 days and 14 days. So having the device attached to your patient beyond 7 days is miserable. Have you had these devices, guys? It's miserable. So 7 days is more than enough. Beyond that, if you still having suspicion, then loop recorder is reasonable. Okay, any more questions? Okay. Thank you, guys.
Thank you.
Thank you.
Thank you.
Thank
Thanks,
you.
everyone. Have a
Thank
good
you.
Thanksgiving.
Thank you, guys.
Thank you, guys.